Welcome everybody to the afternoon session. I have the nice post-lunch slump here, so hopefully everybody can stay awake. But today I'd like to talk to you about infertility as a window into men's health. And like we've heard from a lot of other speakers so far today, improving our fertility is often a multifactorial process, and there's many things that can play into that. And obviously it takes a couple to make a baby, and so we'll spend the next hour going over the male part of that. So I'm a urologist, men's health specialist. I practice here in town with Urological Associates, and I'm originally from Virginia. Made my way out here by way of North Carolina, UNC Chapel Hill. Did my residency there. That's right. Go Heels. And then I spent a year in Houston at Baylor doing a men's health fellowship. So I'm affiliated with the American Society of Reproductive Medicine, Sexual Medicine Society of North America, and I specialize in treating men. I see some women as well, but mostly men, and the various things that entails. So my background with fertility is beyond just medical training. I am married, I have 2 children, but I also have male infertility. I had a very low sperm count, and I had, through some testing and that sort of thing, I was found to have varicoceles. I got those repaired. My sperm count did not elevate enough to avoid IVF, but nonetheless we did IVF. And we did our first IVF cycle. We had 4 embryos, and we were pretty nervous after the first 3 didn't work out. But our 4th and final embryo from that first cycle is our now 2.5-year-old daughter. So it worked. And then we went through a second cycle of IVF, got 12 embryos, and the first embryo turned into our 4.5-month-old son. So I just wanted to share that because I think there's a lot that goes into the fertility process, both for the male and the female, all the testing, all the questions, all the unknowns. And I think as practitioners, sometimes docs can kind of forget about that. But when we look at fertility, and I think this number was mentioned earlier, 50% of it's a female factor, 30% of it is exclusively male factor oriented, but about 20% of cases it's both. And when you add that together, half of it's due to a male factor. And so male fertility certainly is important to realize. And this is sort of old data, but historically about 7 million couples a year, which is about 14 million people, seek fertility services in this country. And again, this is a little bit older data. Thankfully, things I think are shifting in a positive direction. But at the time, only about a third of, up to a third of husbands were not evaluated. So they never got tested. They never had anything done. They just sort of floated through the process. And I think it's also interesting to understand what I'm about to talk about in the context of where we've come with medical procedures that can assist with fertility. And obviously, Dr. Magarelli is a stronger expert on this topic than I am, but you have intrauterine insemination required a high number of sperm to be successful. Then we have IVF in 1978, which actually, where I went to medical schools, was the first successful IVF in 1978, so it's pretty interesting to be there. And then of course in the 90s we have ICSI, or intracytoplasmic injection of sperm, which really requires 1 healthy sperm per egg. And that really revolutionized male fertility treatment, because even those men who have the most severe of disorders leading to a severe low sperm count can still achieve biological parenthood. And so when we see how ICSI has been used from its inception to more recently, you can see that the rates have really doubled over the following couple of decades. And I think now most days it's relatively common practice for couples who have a male factor that ICSI is employed as a method for IVF. So where does that leave the relationship of the male? Because if the guy has a low sperm count, the couple's trying to get pregnant, we're trying to figure out how to treat that patient. So you have the patient, obviously, you have the reproductive endocrinologist, and you have the urologist. And what has oftentimes happened, the patient goes through and they're not getting evaluated. And like I said, some of this data is a little bit historical. And fortunately, here in Colorado Springs, we're very fortunate to have Dr. Magarelli in his practice, and he and I get along well and collaborate very often. But in other cities and other states, that isn't always the case. And what happens is sometimes men get forgotten about and are not really evaluated. And so it's just important to remember that. And I think this is underscored by guideline statements from the American Society of Reproductive Medicine and the National Institute of Health from England and the UK, both sort of highlighting, hey, you know, couples need to be evaluated together. You know, if it's not just a female thing, there's also a male factor that needs to be looked into, and couples should really be evaluated simultaneously. And I know Dr. Magarelli has really taken on that as his goal. So what is my role as a urologist? Am I just a technician who comes in and can retrieve sperm and you know, do those sorts of things, or do I also have a role in helping to treat the affected male to sort of improve their overall health, maybe improve the quantity and quality of sperm, and those sorts of things? And I would argue that the latter is my goal, or at least that's the way I approach it. So today I just kind of want to talk about 4 things. First is, you know, my role is to help diagnose serious or life-threatening conditions that can be associated with male infertility, to identify and successfully treat reversible causes. You know, there are some things that cause a low sperm count or male fertility that can be treated and reversed. And if we can find those, obviously that's important to treat. There are also conditions that are not reversible. And I think there's equal importance in identifying those, because it can really help a couple make informed decisions and save themselves a lot of time and frustration trying things that are not going to be very helpful. And of course, finally, I can help with sperm retrieval and be a technician to help get sperm. But I think there's other things that can go along with it. So we'll kind of take each of these 4 objectives and talk about them individually. So, you know, helping identify other factors that may be going on that lead to a low sperm count. I think there's a pretty large body of data, and I'm going to shrink it down as much as I can in a few minutes here. But the first study to kind of go over is a large series where I actually did my fellowship at Baylor in Houston. It's about 1,200 patients. And we're looking at these patients who all had male factor infertility or a low sperm count. And in that population, only about 1% had underlying medical problem that was discovered as part of the workup for male infertility. But and I know that sounds like a small number, but it's really important to remember that these problems were quite significant. Brain tumors, testicular cancer, conditions that these patients otherwise had 0 symptoms that would have tipped off anyone to go looking for these conditions. These are otherwise just normal, healthy guys walking in, and they're having some fertility issues. They get checked and we find something else going on. A few years later, a similar study was done at the Cleveland Clinic. Similar findings, about 6% of male patients being evaluated for infertility had other major medical problems, everything from a cancer that got diagnosed to hypothyroidism, diabetes, things of that nature. And so it's important to remember this going forward. So we'll kind of take these into individual categories and unpackage them. And we'll talk the most about cancer because obviously that's a pretty significant thing to find. But data looking at the California Cancer Registry and several other large IVF centers in California, it's a large population of patients, about 20,000, looked at infertile men and found that compared to the general population, infertile men had a significantly higher risk of developing not just any type of prostate cancer, but more specifically high-grade prostate cancer, which I'm not going to talk about prostate cancer today, but those are the type of prostate cancers that we really want to find and treat early. And that increased risk was about 2.6 times higher. And the same thing can be said with testicular cancer, about a 3 times higher rate of testicular cancer in those same patients. Similar study looking at a larger population of patients nationally through a large database, comparing a population of men with infertility versus men who had a low sperm count because they had a vasectomy, which obviously they should have a 0 sperm count after a vasectomy, versus another group of patients who were completely normal. And you can see here, not to dive into the statistical details, but basically any number that is exactly 1 means that there's no increased or decreased risk. Less than 1, your risk is decreased. But over 1, as you can see here, all of these categories mean that there's a higher likelihood of finding these conditions in these patients with infertility. And then obviously with infertility, there's quite a spectrum of abnormalities that men may have. You can have, a slightly low sperm count in one category, or maybe your motility is a little bit low. And then on the other end, there's men that just have no sperm at all. And there's everything in the middle. And when you look at which male infertility patient really has a higher risk of having these other medical conditions, this particular study showed that it was really those men that had a 0 sperm count had the highest likelihood, 2.9 times higher likelihood of being diagnosed with cancer versus the other categories of just a low sperm count. And this is a graph from that same study, and you can see the red line is the men who had a 0 sperm count versus the blue line at the bottom are men that just had a low sperm count or mild abnormality, and that risk of cancer was much higher in men with a 0 sperm count, what we call azoospermia. Shifting gears out of cancer, looking at just other medical problems. This is a study from Stanford University, almost over 9,000 men, and they looked at other chronic medical conditions, and they were trying to identify which ones were more likely to be diagnosed in men with infertility. And oops, let me go back. You can see here we have everything from endocrine, which would be usually like diabetes, things like that, or hypothyroidism, skin disorders. There's reports of skin cancer in young men with infertility that otherwise aren't really seeing a dermatologist, but they come in for infertility and then they can get sent to a dermatologist and get evaluated. So a lot of things that you wouldn't ordinarily associate with infertility. Low testosterone. You can't turn on the radio or drive down the highway and not see a billboard addressing low testosterone. But this study looked at testosterone levels in men based upon what their sperm counts were. And so on the far left of the chart, those are completely normal men with normal semen parameters. And as you move to the right of the slide, your sperm count's getting lower and lower to the far right column, where those are men that have a 0 sperm count. And as you can see, the rate or the number of men with low testosterone rises as the sperm count falls. So certainly there's something going on with men that have a 0 sperm count, that there's a degree of testicular dysfunction that's going on that affects not just sperm but also testosterone. And then finally, mortality. What's the likelihood of living another 10 years for any reason? And there's a study looking at almost 12,000 men, and you can see in the graph here these lines, and the top 2 lines were the groups of men that were either normal and had normal semen parameters, or just maybe one category on their semen analysis was a little bit off. Like I said, like a little low motility or a low sperm count. And then the bottom figure, these are men that have almost all of their semen analysis parameters are abnormal and low. And that, the more abnormalities you have in your semen analysis, the higher likelihood these men have of death from any cause in 10 years. Now, if you look over on the far left, this graph, these numbers are not, 1 to 100, it's 1 to 2. So I mean, it's not like guys that walk in and get checked for infertility, walk out and die in the parking lot. I mean, this isn't, I don't want everyone to like get spooked here, but I think I really want to underscore the fact that for a long time we've viewed, well, if I'm a little overweight or I see a lot of guys for erectile dysfunction or low testosterone, we kind of lump that into, well, maybe this is an early indication that you have some other medical conditions going on. And I think it's important to remember that fertility falls into that category as well. And this just summarizes what we've talked about. So, infertility can be a barometer of men's health overall. And myself included, seeing as I went through this process myself, I didn't want to go see a doctor and talk about it and get checked. And most men don't want to go see a doctor. But I think it's important to remember that there's some really important health benefits that can be realized by getting evaluated, and you make your wife happy by helping her out in the process as well. So shifting gears to kind of the second topic I wanted to talk about, and that is my job, at least the way I view it, is to sort of identify and try and find things that I can fix, that we can improve to make the sperm count healthier. And so let's get a little better understanding about what we can do for that. So this is a list of, and this, believe it or not, isn't even comprehensive, but this is a relatively short list of all the things that can contribute to male infertility or a low sperm count. And unfortunately, at the very top there, you see this word idiopathic, and what that means is we just don't know. And really, even today in 2019, about a third of men that come in with a very low sperm count or a zero sperm count and have infertility, we just don't have a great explanation. And I think science is we're still catching up in trying to bridge that knowledge gap. But most of these other conditions on this table are known, and many of them do have treatments. And so I'll kind of focus on the first couple, and the first one is a varicocele. So if no one's ever in the room has ever heard of a varicocele, it's essentially just a varicose vein of the testicle. And so we'll talk a little bit about what that does to the testicle and how it impacts how the testicle functions, and then why fixing it is important. So not trying to be too gruesome with the picture, but you can see that's that big dilated cluster of veins in the upper part of the scrotum. That's a classic example of a varicocele. And we know that about 1 in 5 men walking around everywhere has a varicocele, so they're very common. But when you have men that have a low sperm count that come in to get checked, that number's up to 50%. So certainly some men do fine, and they're doing great. The varicocele is not a factor or a problem at all. But when you have a low sperm count or infertility, a varicocele can be one of what's oftentimes many things that can be contributing, whether it's stress, emotional issues, a varicocele, hormone abnormalities. All these things kind of pile together to make a sperm count diminish. And so a varicocele in particular has a negative effect by elevating temperature. We've heard about temperature already several times today. Guys, stay out of the hot tubs and don't have your laptops on your lap. Well, a varicocele is essentially like having a laptop on your lap 24/7. The testicle just runs hotter than it should. There's also pressure from the blood that backs up, and you can see in this picture, this is a X-ray where there's been some dye injected into the veins that go to the testicle, and you can see that dye just backs up into the testicle and creates a lot of pressure, and then that pressure leads to poor blood flow, and you can get oxygen deprivation, and sort of the toxins from the testicular metabolism have a hard time leaving. So I tell guys it's kind of like living in an apartment and you never take out the trash. You can live there, but it's just not very fun, and that's kind of how the testicle is with a varicocele. So not to get too far down into the science part of this, there's really 3 populations of cells in the testicle that contribute to how the testicle functions normally. In the first population, called Leydig cells, are important for testosterone production. And again, not trying to get too far off track into testosterone, but just as another marker of testicular function overall, studies looking at men with varicoceles, this one in particular, about 300 men who have a varicocele versus 500 men who do not. When you look at the testosterone levels, the men with a varicocele tended to have a lower testosterone, on average about 416 versus 469 in men who are normal. And then if you fix the varicocele and check the testosterone levels 3 and 6 months later down the road, 70% of the patients had an increase in their testosterone level after the varicocele was fixed. And that number increases about 100 to 150, and there's numerous studies on this topic, but that's kind of a ballpark expectation from that. But what's more important to fertility are the germinal cells. And so, the germ cells in the testicle are really what contain the DNA that, as our testicles make sperm for our entire lifespan, all the genetic material that goes into our sperm are basically copied off of the germ cells. And so if there's a problem with the germ cell, that just gets propagated every time you are copying that DNA to make new generations of sperm. And so with the germ cells, it's important to look at this with, how are sperm counts improving with varicocele repair, and how does that impact success with assisted reproductive technologies like IVF and ICSI. So a couple studies to go through. Again, not trying to overload you with data, but I think it does really paint a clear picture. This first study is 22 couples who had gone through an IVF cycle and were not successful. They had no children were born from the first cycle of IVF. And all the men in these couples had varicoceles. They got those varicoceles repaired. And this table below, you can see in that left column right here, this is the fertilization rate of the eggs with the sperm and the cleavage rate before varicocele repair. And if you go to the right one column, you see how those numbers improve after varicocele repair. And what's really important at the bottom is this 20% here. That's a 20% pregnancy rate. So these couples had a 0% success rate with IVF, got the varicocele fixed, did another cycle of IVF, and now 20% are hopefully taking home a child. Now, 20% is not a great number. There's 80% that still didn't. And I mentioned this earlier, this is on usually a list of several things that we talk about that we can do to improve testicular function, improve sperm production, better quality, better quantity of sperm. A lot of things, though, are not easily fixable. A varicocele is something that we can fix. A larger study, about 240 couples, where the male had male factor infertility and had a varicocele. And you then split that group into those who had the varicocele and decided not to have it fixed versus 80 in the smaller group who did have it fixed, and then everyone went on to do IVF. So in the men who had the varicocele repair, there was a significant increase in not just the total sperm count, but also the number of sperm that were swimming. So that how many million sperm were swimming, and those numbers were anywhere from double to triple what they were before the varicocele repair. But honestly, that doesn't really matter. What really matters is how did they do with IVF? And so when you looked at the pregnancy rate with IVF, the men who did not have the varicocele repaired experienced about a 48% pregnancy rate. And this data sort of tried to equalize all the other factors that could be different between these couples. But 73% pregnancy rate in those that had the varicocele repaired, and then live birth rate, 37% versus 51%. So again, we're not hitting the ball out of the park, but if you can get a 10 to 15% increased live birth rate with IVF, with everything that goes into IVF, both financially, emotionally, all those factors combined, I mean, that's an important number, I think, to remember. For couples who didn't quite need to do IVF, but we're just looking to do intrauterine insemination. 58 couples in this one particular study, about half and half had, one half had a varicocele that was not treated, the other half had a varicocele that was. And the groups are very similar in terms of how they did the IUI process. And again, you can see the live birth rate was much higher in the group of patients who had the varicocele fixed versus those who did not. And then the last piece of data on varicoceles before I move on, and this is someone who was a good friend of mine from UNC. He published his work in fertility and sterility, but basically I made an analysis where they combined all the studies on the topic into one analysis. So it was seven studies, about 1,200 patients, and looking at men that had a very low sperm count or a zero sperm count, also had varicoceles. Some got them fixed, some didn't, but everyone went on to do IVF, and they found that, again, varicocele repair improved the live birth rate in both men with a low or a zero sperm count, and varicocele repair improved the likelihood of finding sperm in those men who had a zero sperm count. They were more likely to have sperm found during a surgery to look for sperm, and then when those couples did IVF, they had better IVF outcomes and success rates. So I think it's important to remember varicocele repair should be considered and can have benefits for couples, depending on if there's a low sperm count or even a zero sperm count, and not just improving a sperm number, but improving the outcome and the pregnancy rate and the live birth rate going forward. So what is a varicocele repair? And I'll just briefly talk about this. These have been done for 30, 40 years. This is not like a new procedure. What is new is how we approach it. So traditionally it was a bigger incision, more like an intra-abdominal surgery, honestly. But nowadays, in the last 10 years or so, the gold standard is doing what's called a sub-inguinal incision, which avoids having to go through any of the muscle or fascia, and you're maybe a centimeter or two below the skin surface, and you can get to where you need to be. And then this is what we're looking for. So this is the spermatic cord, and I do the surgery with a microscope. Most people that do a subinguinal varicocele use a microscope because you can see just at first glance, this isn't really obvious what you're looking at, but when you use a microscope, you use a microdoppler, you can start to see that there's an artery and then there's several veins that are dilated, and the goal is to ligate those veins to reroute the blood flow into healthier veins so that instead of all that blood backing up into the testicle, it can circulate like it's supposed to normally. And so that's kind of what we see in the operating room. So varicocele is a common cause of testicular dysfunction, and fixing the varicocele can improve not just sperm count and sperm quality, but more importantly, can improve success rates with IUI, IVF, and all those things. So the other correctable thing I want to address on this list is the third most common, which is obstruction. And this will be a little bit more brief than the varicocele discussion, but obstructive azoospermia, that's where a man has a 0 sperm count, not because he's not producing sperm in the testicle, it's just there's no way for the sperm to get out. And most of the time we see that as a result of a vasectomy. So, at one point in life, thought children were no longer in the future, and then had a vasectomy and things change. But it could be from an injury, it could be from an infection, or in some men, they just have, for whatever reason, a very high pressure buildup in the epididymis, and it, some of the tubules blow out and get obstructed. Or, as we'll talk later, there's some genetic things that can lead to this condition as well. So oftentimes correcting obstructive azoospermia requires microsurgery, and I think it's easiest to discuss kind of in the framework of a vasectomy reversal, but there's other procedures that can be done as well for obstructive azoospermia. And I don't want to go too far into vasectomy reversal. There's several factors we look at to determine if a patient's a good candidate, and I think that's probably the most important thing to take away from this is not everyone is a good candidate for a vasectomy reversal. So just because you have a vasectomy doesn't mean we can put it back together. And so you have to be very selective with who, at least I am. I'm selective with who I recommend the surgery to because, for some folks it may not be the best use of their time and resources, and they're better off seeing Dr. Magarelli and doing IVF, and we go through things that way. But these are some of the factors that we consider. In those patients that we do a vasectomy reversal, it's important to do it. I do a 2-layer reconstruction with microsuture, and you can see in the bottom right corner, these are sort of the really small sutures starting to bring together the mucosal layer, and then we bring together the outer muscular layer, which you can see in this picture here is the vas completely reconnected. And again, in the properly selected patient, not just everyone that comes in with the history of vasectomy, but in the properly selected patient, 95% can expect the return of sperm to the ejaculate. In other patients that have either a vasectomy and they have a lot of pressure buildup over time, or it's been a longer period of time, and the epididymal tubules are dilated and obstructed further upstream closer to the testicle. Or I've seen this several times in patients that have had trauma or an injury or an infection, and they have otherwise normal sperm production. The sperm just can't get out very well. You can go and try and find these dilated tubules, and I think it's hard to see in this picture, but down sort of in here, there are these really dilated tubules that you can see under a microscope, and you can connect the vas deferens or the vas tube directly to those tubules. And again, I don't want to get into a huge discussion about all the details, but suffice it to say, that's sort of like a intraoperative picture of the vas. Obviously, vas is a large tube connected to a very tiny epididymal tubule, but it can be successful, not nearly as successful as a vasovasostomy, but can be successful for some of these patients, and it allows sperm to return to the ejaculate. And again, I think proper patient selection is key here, because not everyone is a good reversal candidate. If they are, though, it is an option because it can be cost effective. In this one study, again, this data is a little bit dated, but this comes up about every 3 or 4 years at our national urology meetings, talking about cost and all these other factors. But in the right couple, the right patient, where the only factor is this vasectomy, and it's otherwise a good situation, can be cheaper potentially. So shifting out of the realm of what we can fix, what we can focus on, what we can try and improve, to things that we cannot. So untreatable causes of testis failure or male infertility, and pretty much all of this boils down to genetics. There can be chromosomal defects where you have addition of extra chromosomes you're not supposed to have, or you're missing chromosomes that you should have. There's relocations and translocations where basically you have all the genetic material you're supposed to have, it's just in the wrong order. So we have all the chairs in the room that we need in the room, it's just they're not by the table, they're over in the corner. That can cause some issues. The Y chromosomes, that's what makes a guy a guy. Women do not have a Y chromosome. And so there are specific things to the Y chromosome that can be abnormal. And then, specific genetic mutations in certain genes can also have an effect. And so whole chromosome duplication deletion, not a very common finding. I would say probably 5 to 7% of men who have a 0 sperm count. You do genetic testing, you'll find this, but it is important to find because, as we'll talk about a little bit later, some genetic conditions will tell us very definitively that we have a very low likelihood, or very small chance of finding sperm or being successful with IVF. But in this one particular condition called Kleinfelder syndrome, where you have an extra X chromosome, there is hope that with surgery and doing a microscopic search for sperm in the testicles, you have an expectation of about 50% of finding sperm in those patients. And so it's important to know that before and while you're talking to the couple and going through the process, so that they have realistic expectations going forward. And then of course the Y chromosome, I think this is the easiest one to focus on because this is exclusive to the male patient. And as you can imagine, if there's a section of the chromosome that is damaged or missing or deleted, that could lead to some sperm production problems. And this work was done mostly back in the mid-90s. And again, not super common. Only about 6% of men who have a very low sperm count and about 10% of men who have a 0 sperm count have some abnormality in their Y chromosome, particularly these deletions I'm about to talk about. But nonetheless, when they're there, it's important to note. So there's 3 deletions that we really look for that have a very clear impact on sperm production. And so there are these AZF A, B, and C deletions. And data looking at patients with these different deletions, and how did things play out? When us as a urologist or whoever went to go look for sperm, because a lot of times these patients have either a very, very, very low sperm count or 0 sperm count. When we do a surgery to go look for sperm, what's our success at finding sperm that can then be used for IVF? And when you look at the AZF A and B deletions, there was never any success of finding sperm, versus the C deletion there was. And so sounds a little bit morbid. I'm not trying to beat up on things that are not contributing to making babies here, but it's also important to understand in the evaluation if there's a realistic chance that we're going to be able to find something that we can fix, or something that's not fixable. And there are options to achieve parenthood, beyond that. The last genetic thing to talk about are cystic fibrosis gene mutations. So cystic fibrosis as a disease is not very common, but it's certainly very significant. But a lot of patients, particularly Caucasian ethnicity patients, will have mutations in the CFTR gene and not have the disease, but they just walk around with a mutation in their everyday life. How that relates to fertility is, and this is a little bit of a gross picture, I apologize, but this is a testicle, if you didn't realize that. And this is normally there's this thing called the epididymis that hangs off the side of the testicle that collects the sperm as they are produced. And as the sperm move through the epididymis, that's where they gain the ability to swim. So sperm that have gone through the epididymis are fully mature sperm. In this picture, you can see the epididymis stops right here. So it's what we call an epididymal remnant. And so in some patients who have, in fact, the large majority of patients who have mutations in the cystic fibrosis gene, they can have a condition where on either one side or both sides, the vas tube is just not there. That's how they were born. So we know that about 80% of patients that do not have a vas deferens tube on both sides can have these mutations. About 40% that have a missing vas tube on one side can have a mutation. And having these mutations is very important because if your partner has a mutation as well, and now the couple, you're dealing with CF mutations in both partners, of the male and the woman. When you do, and since most of these people have to do IVF because we have to retrieve sperm and those sorts of things, it's very important for the IVF process to know this going into it, because then it may be a good idea to test the embryos for their genetics and make sure that these mutations are not being passed on to the children. So lastly, I'll finish up with sperm retrieval. So kind of like I talked about at the beginning, absolutely we can retrieve sperm surgically, and I think I have this at the bottom of the list intentionally to sort of highlight, we want to go through the whole process. We want to evaluate the patient from head to toe, do labs, do an exam, take a good history, and try and correct everything that we can correct before we say, okay, this is it. We have done the best that we can do, and we have to go look for sperm surgically. So in general, there's about 3 different places that we can get sperm. So if the patient is ejaculating sperm and they just have a low sperm count, well then obviously you have sperm that can be ejaculated, and that's a lot easier than surgery. Also, you can get sperm from the epididymis. I kind of alluded to that a few slides ago, where sperm in the epididymis are fully mature sperm. So they are just as good as the sperm that come out in the ejaculate. They're fully mature, that sort of thing. And then finally, you can go all the way up to the testicle to get sperm, and that works well, and those sperm can do a good job. But there's sometimes some ambiguity with which sperm are the most mature and which ones are not. And I think having that motility factor really helps out with, particularly in couples that have to do IVF. It really helps the lab identify the best sperm to use for the process. So this picture kind of goes through just sort of like a 10,000 foot view of sperm retrieval. So in the top left corner, we can do a sperm retrieval from the epididymis. So that's that same picture I showed you where the patient has that cystic fibrosis gene mutation and has an absent vas deferens. We can go to the epididymis, even though it's a small remnant, we can still get sperm from that area, and that can be used for IVF. In the top right corner, we can go to the testicle and get sperm. The picture that you see there is kind of just a small testicular biopsy where we make a little small incision and get the testicular tissue to come through the incision, and we can use that tissue. But in more severe cases, if we have to go and take a deeper look, we can use a microscope and go through basically all the tissue in the testicle to see if we can find sperm somewhere in there. And that's what this picture in the bottom right corner, it's a little bit blurry, but that's kind of what that's depicting. So just for the interest of time, I'll kind of just focus on that top procedure, which is the microscopic epididymal sperm aspiration, or MESA. And again, for patients that have an absent vas deferens, or there's been an injury or something to the epididymis and things are obstructed, or vasectomy, there's a vasectomy in the past and the patient is not a good candidate for reversal, then we can do this procedure. And again, this is the same picture I used earlier. It's not the best, but I think this other picture helps. So this is I know it's kind of blue, but you can see here, this is a dilated epididymal tubule that you can see under a microscope, and I use a little bit of blue dye sometimes to help make those tubules a bit more visible. But that's what we're looking for. We go, in the operating room, we use a microscope to go through the epididymis and try and find these dilated tubules where they're dilated because downstream there's a blockage, and upstream we're hoping to find a large quantity of healthy, mature sperm. And so we go through and we basically find, as you would expect, the good quality fluid is very cloudy, milky white, and that's usually indicative of a large quantity of sperm. And we aspirate that with a syringe, do some things to get it down to this, where in the bottom right corner you look under a microscope and you have normal, healthy, swimming-looking sperm. Similar to what you would see is if you were to, if you had a normal patient who just ejaculated a sample into a cup. And so it really is helpful to have those good mature sperm. So advantages to this particular procedure: large numbers of sperm. So we can get on the order of anywhere from 2 to 3 million motile sperm up to 10 to 12 million motile sperm. Obviously with ICSI you only need to have 1 sperm per egg, so that's a little overkill, but I think it's also nice to have a lot of sperm frozen as a backup. And for these men, they don't like to have surgery done on their testicles very often, so that way we can get everything with one procedure and saves them multiple procedures going forward. And then obviously I haven't shown a lot of studies and data on this point, but you can have better outcomes with IVF and ICSI when you use epididymal sperm or ejaculated sperm as opposed to testicular sperm. Downsides to the MESA: well, you have to be comfortable using a microscope, and you have to usually do it in the operating room. So those are the 2 downsides. But I think there's, like everything, there's ups and downs to both, and it's certainly worth discussing. So I think that kind of wraps up what I was going to talk about. And I think the really take home I want people to walk away from this is, it's important to remember, to get the male checked out. I mean, there's a lot of things that could be going on, and we could find things that have nothing to do with your fertility that's important for your overall health, and we may have some things that we can do to help improve your overall fertility and sperm count. But it's important to have that evaluation. So thank you. Appreciate it.